this is just a little overview that I hope will set the tone for the rest of the speakers who I'll introduce before each talk. What we're really here to talk about is glioblastoma, because when we talk about brain tumors, there are many brain tumors, but for you providers, you all know that the most common brain tumor in adults, other than meningioma, is or metastases, is malignant glioma and glioblastoma. So I guess I can. And just historically, let's go back to the 1960s when I was born, and at that time, median survival with a biopsy was about 3 months, and then with an extensive resection, you gain about 3 more months, which is a 6-month median survival. Not so great. And then with advent of radiation treatment, we doubled survival to about a year, which is still not that great. And then chemo helped a little bit as well. Big advance, I guess you could call it, depending on how you look at it. In 2005 were back-to-back papers in New England Journal showing that temozolomide could improve median survival from about 12 months to about 15 months. But if you broke that down, it's really due to about a third of the patients who have a certain type of molecular modification so that their MGMT protein doesn't work that allows the chemo to work. And they're the ones that really pull the curve over. Still, that was an advance. One thing that kind of gets overlooked, and Dr. Berger will probably discuss this, is that novel techniques in surgical extent of resection have actually shown significant improvement in survival. 5-ALA is a molecule that we can give patients to improve surgical resection, and that shouldn't be overlooked, and that has had pretty significant benefits, especially for low-grade gliomas, which we're not really focusing on here today as much, at least what I'm talking about right now. Then some unexpected things have happened in the last couple of years. We've seen that NovaCure tumor treatment fields, alternating electric fields, which apparently put dipole charges on microtubules and block ability of tumor cells to divide, have shifted the curve a little more, and so this clinical trial was stopped during the middle of the trial to allow this to be available for patients for glioblastoma. So despite these advances, I think what we all realize is for glioblastoma, we need something big to move the field significantly, beyond 1.5 year, beyond 2 years survival to median survival, 5 years. Let's make this a chronic disease if we can. And we're going to hear today about rational approaches. I like that concept. That means you think you know what you're doing and you apply something, but sometimes we don't really know what we're doing, but we try everything. And we also have to be open to the possibility that we don't know some things and we may find unexpected results. One of my favorite quotes about humility is by one of the least humble people I've ever seen. But it's kind of true. They're the known knowns. They're the things we think we know. They're the known unknowns. That is to say, the things we don't know, and we don't know, but then there are also the unknown unknowns. And these are things we don't know. And I think as we move forward, we have to be open to the possibility that we actually don't know everything about this disease, and we have to keep our minds open to unexpected findings and be able to analyze them and convey those findings to help patients. So among the knowns, we've kind of depleted our ability to pull everything out of those that we can. There are innovations still to be gained in surgery. Radiation, I think that's pretty much, we pushed the envelope to the extent we can. Chemotherapeutic approaches, I think we've beaten that horse pretty hard. There are targeted pathway inhibitors, signaling pathway inhibitors, angiogenesis inhibitors, a whole new field of immunotherapy based on non-specific sort of turning up the whole volume of your immune response, and specific targeted inhibitors we are starting to understand. And then cancer stem cell biology, which we now think is fundamental to the process of recurrent tumor we're getting more of a grasp of, and that may lead to ways to approach things. We have a lot of novel discoveries in the last 10 years of specific molecules that we think are involved in the biology of these tumors, and we've jumped on those, but some of the results haven't provided the outcomes we've liked, including the recent failed improvement in survival for EGFR V3 immunotherapy. IDH1 mutation is something that's novel, but it only applies to a small percentage of glioblastomas. Cytomegalovirus is something that my group is very interested in, and Dr. NovaCure will discuss, which may hold some unexpected possibilities. And then in the unknown category, we have a lot of things we know we don't know, a lot of the genomics and fusion proteins and other personalized approaches we're just scratching the surface on. There may be more to be learned from alternating electric fields or radio frequency energy, a lot of things that are coming down the pike that are not really in our toolbox that we have to be open-minded about. And then there are a lot of unknown unknowns. What are we going to find when we do immunotherapies with certain molecules? What are we going to find when we look further for possible viral infections? Will that show anything that could be a major advance? This is just a slide to show that, early on in this last 25 years, when I started my training in 1992 with Dr. Prados and Dr. Berger here at UCSF, we were just starting to put together this map of all the major signaling pathways in glioblastoma. We know that PDGF and EGFR receptors are highly expressed and amplified. We know that VEGF receptor, we learned that that was critical for angiogenesis and the integrin pathways. And you can see about every possible molecule has been thrown at every one of these pathways without any major advance. But it may be that what we need to do is continue this approach and have a more holistic way of thinking so that we target multiple things at once, because these tumors are chameleons and they're like the whack-a-mole. You hit one thing and then it goes around and something else pops up. Some of the big focuses of treating these tumors has been to focus on amplification of EGFR and the identification of a specific mutation that occurs on the EGFR receptor in about a third of the patients. These approaches, while they seem on the surface to be very promising, have unfortunately not panned out as much as we would like. In the last decade or so, there's also been, as I mentioned, a fundamental understanding and approach to the recurrence of glioblastoma that suggests underlying the recurrent tumor biology are a subset of tumor cells that are classified by different people in different ways, and they're very difficult to pin down. If you write a paper on them, you'll be criticized for calling them tumor stem cells. They're called tumor initiating cells, whatever you want to call them. We do have pretty good models in mice that if you treat these mice with temozolomide and you kill 99% of the tumor cells, a subset of those cells will survive, and they often will become more resistant to therapy. They have slower cycling than the rest of the tumor cells. They have a different inherent biology. They express certain markers like typically CD133 and nestin, and these guys are like the queen bee of the beehive. If you don't kill the queen bee and you kill all the other bees in the hive, the whole hive will be repopulated. So there's a lot of effort to focus on these cells and figure out why they are uniquely able to survive, and how can we target them as well as the rest of the tumor. And then really in the last 5 years, there's been a big appreciation of what many of leaders in this field, including one of my really dear colleagues who passed away last year, Andy Parsa, focused on, which is the immunotherapy or immunological aspects of these tumors. And publications going back to the 1970s have shown that for whatever reason, glioblastoma patients have very weak T cell function, very poor immunity. They're anergic to typical skin tests. Why is that? And not only are they globally or systemically immunologically compromised, but at the tumor level, I kind of look at this picture and you have the cells, the tumor cell is blue and that yellow kind of haze around it, I kind of see that as the immunosuppression force field. These tumors are in a basically an immunoprivileged little domain. And a lot of this now we understand could be due to some of the factors that are expressed on T cells or on the cell surface, like PD-1 and CTLA-4, and a lot of other tumors are now being treated by blocking these receptors, which sort of systemically gives you an amped up immune response. It can also lead to autoimmune disease. But if we could put a inhibitor on the PD-L1 protein on the tumor surface, we could maybe make those tumor cells a little bit more targetable, if you will. So the pot of gold at the end of the rainbow is to find specific targets on the tumor cells that your immune system can very intelligently and specifically target, and then maybe in combination with amping up the whole immune system by these checkpoint inhibitor pathways, you can get a combination effect. And Dr. Prinz from UCLA, who has kindly stepped in place of Linda Liao, who he works with, he kind of runs the immunotherapy lab at UCLA, will be discussing at length the immunotherapy approaches. So if you just look at what is out there now, there are dozens of clinical trials, which is great, many of which are phase 1 trials looking at little pieces and bits of molecules that people are interested in to target glioblastoma. The ones in green are a couple that we've been involved in. The DCVax trial is essentially the UCLA group came up with that, Dr. Prinz. Other trials, ICT 107, looking at dendritic cell vaccine targeting antigens and commonly found in glioblastoma. There are a bunch of other trials here, one that Dr. Prinz will probably talk about, NY-ESO1, which is a molecule we can upregulate by treating the tumor with another chemotherapy and then target it. There are some phase 1 trials trying to approach treatment of cytomegalovirus, which our group has found in the tumors, and group at Duke has had some success with preliminary studies in that area. A lot of clinical trials using the checkpoint inhibitors are popping up in Opdivo, which is anti-PD-1 and anti-CTLA-4 molecule checkpoint inhibitor. Clinical trials are ongoing here. We've been involved in the TOCA trial, which is a live retroviral infection that has a prodrug or a gene that converts a prodrug into a toxic metabolite. And this is something a lot of you have probably heard about. That's somewhat related to the virotherapy concept, that if a viral infection kills tumor cells, it'll not only set off an immune response that may be an immunotherapy type of response, but a tumoricidal response. So the concept with TOCA is you get kind of a chemo drug, a viral response, and this virus proliferates in tumor cells, but not normal. So, a lot of very complex combinations of concepts going into these trials. I'm not going to really go over a lot of these other things, but as you can see there, adoptive cell therapies, I think one of the most exciting areas is chimeric antigen receptors. So if we could find specific molecules on glioblastoma cells that are targetable, we can now, I say we, the folks over at the Hutch primarily have been innovators in building molecules that can hone T cells directly into these particular molecules for a robust T cell response. We're involved also in a clinical trial, Abbott 414, which is targeting the over amplification of EGFR with another cytotoxic molecule. And I've already mentioned this oncolytic virus therapy. A lot of you heard about the preliminary results from Duke that was on 60 Minutes, and I think that's very exciting potential. And then, as I mentioned, there are the things that are sort of the unknown unknowns. Who would have expected that a clinical trial would be approved showing evidence of improved survival with essentially a battery that has lateral and forward and backwards alternating electric fields, which sort of stun microtubules. But there, I guess we'll hear debate about that today, maybe, that there is evidence that that has improved survival, not something that many of us were seeing on the horizon. We've also been involved in a clinical trial with a very innovative device called the Voyager from a company here in Seattle that uses radio frequency energy, and that's an ongoing trial with some interesting preliminary results as well. But given the fact that there's this really plethora of work being done in multiple aspects of immunotherapy and all aspects of targeted therapy for glioblastoma, in trying to assess what we really need to drive this field to the next breakthrough, I think we have to continue doing all of these approaches, but we also need to, I believe, work together. And my role model in this concept is Dr. Hood, who will speak next, who understood probably before anyone else in the world that to make big gains, sometimes you just need to get the whole system approach, take the genomics, take all of these things and analyze the results, have measurable quantitative ways of measuring what's happening when you perturb the system, and then build models that tell you, how to measure what's benefiting the patient or what's benefiting the system. It's called systems biology, and he started the first institute here in Seattle for systems biology. I might say as a side, one of the interesting things that has evolved, and he may speak about this, is a spinoff company called Airveil is now taking healthy volunteers and analyzing multiple aspects of their biology, the genome, microbiome, and by putting all of this information into data networks, they're actually discovering things that they had no idea were linked. And so I guess what I'm saying is, as the brain tumor research community, I hope that we can start assembling large groups of people and researchers that can combine data so that it can be analyzed to see if there are unknown unknowns that pop up and maybe lead to unexpected findings. And one thing I'm going to talk about at the end in my talk, I think I'm the last speaker, is biomarkers. I think that's a broad term that can be used, but I think that one thing that's lacking in our efforts is to treat these patients are sort of concrete markers. We have progression-free survival, PFS, we have overall survival. These are obviously the most important. But between someone having a resection of a glioblastoma and recurring and having the tumor come back a year and a half later, other than MRI, which is fuzzy math, if you want to call it that, or very difficult to interpret sometimes, we don't really have good readouts of what is happening in real time. So I think a very important aspect of the future of this whole research arena is to develop ways to analyze, measure what's happening. So what is around the bend? I think that I've been very fortunate to assemble a group of really the world's leaders in the concepts that are not being necessarily known even about by the lay public or the research community as much, but cutting edge and things that actually are around the edge. which I believe will be the types of approaches that could lead to big breakthroughs. I mean, they range from things we know that we can improve, like surgical techniques Dr. Berger will mention, to targeted therapy approaches, to high throughput drug screening, which will be discussed by Dr. Hoti, my colleague here, based on some clinical trial work we're doing. Targeted immunotherapy approaches, Dr. Prinz, cancer stem cell targeting, we're going to talk about that. Antiviral therapies, Dr. Nauclair will discuss the use of antiviral drugs as a possible treatment modality. And that is my segue slide to sort of lead to how I got here and why this mission was started and why this course is being given. So Greg Foltz and I were friends. He was exactly my age, and I guess it was the fall of 2012. I was at a ABC Squared course in San Francisco, sitting with Greg and Catherine Ivey, and said, you need to come up and check out Swedish Neuroscience Institute. And I had just moved from San Francisco to Mill Valley, and I told my wife that I was going to go look at a nice program in Seattle, and she said, we're not moving again. But Greg was a persuasive person, and I found that this was a unique opportunity. Where else in the world could you have a research lab next to your office, next to your clinic, 2 minutes from the operating room, and be able to integrate all these things and work with a team that was really focused on doing innovative work in the lab and allow you to do surgery. And when I came here, Greg had already been funded to the tune of about $5 million by the Ivy Foundation. And one of the projects is now in review at the journal Science that I'll discuss. It's the Ivy and Allen Brain Institute Atlas for glioblastoma at the molecular level. He also initiated some work in cancer stem cell high throughput screening. That has evolved into our clinical trial, which is underway. It's the first clinical trial, and Dr. Hoti will discuss this, where tumor cells from patients are grown so that the cancer stem cells survive, and then they're treated with dozens of compounds, up to thousands of compounds, to see which ones are the most effective for any given patient, and then a personalized cocktail of these drugs will be given to the patients. Greg was a leader in pushing the envelope with genomic studies. He did a lot of collaborative work with people around the country. And really, because of his vision, this small research lab, Ivy Center, has had quite an impact by being collaborative. And sort of the MO of our group is to break down barriers and provide reagents and collaborative information and specimens to anybody who is interested. And Greg became passionate about brain tumor treatment because of a close friend who died of a glioblastoma when he was on his way to being a concert pianist, and he decided to go to medical school and devote his career to fighting glioblastoma. And part of his analysis, being a brilliant guy, was that if he wanted to fight this disease, he needed to hook up with someone who was a forward thinker and understood the complexities of cancer biology. So he worked for Dr. Hood and started a collaboration that has led to a lot of the fruits of the work that's ongoing, and allowed me to come in and sort of take over. As most of you know, he went after he recruited me. About a year later, when I was almost on my way here, he finally told me that he'd been diagnosed with pancreatic cancer and passed away about 3 months later. So because of Greg, we have this Ivy Center, And in honor of Greg, a endowed lectureship was established, and it couldn't be any more appropriate to have Dr. Hood be the first Greg Foltz endowed speaker.